Assalamu alaikum. Ladies and gentlemen, dear colleagues, good morning. And thank you a lot for being with us today early morning. And I would like to congratulate the organizer for such nice meeting. Thank you, Dr. Abdullah Shah, for your kind introductions. We interventional cardiologists, when we take our patients to the cath lab and we open the artery, we put a stent, we did not cure the patient. We just manage the patient. Our patient will continue to be an ischemic heart disease patient or coronary artery disease patients. So we need things to stop the progression of this disease. We don't want these stents to get occluded or a new de novo lesions and to bring him again and again to our table. So today my talk is about the lipid management, which is something essential, very important for our ischemic heart disease and even for our cardiovascular disease patients, including those with a stroke or even peripheral artery disease. It's a very short time, 25 minutes to cover this topic. We need a full session, but I will do my level best. When it comes to this lipidemia, all of you knows very well, and it's well demonstrated, that LDL cholesterol is the main driver for atherosclerosis. Many studies have demonstrated clearly a log linear association between absolute exposure of LDL cholesterol and the risk of atherosclerotic cardiovascular disease. In the last 30 years, many studies demonstrated this clearly, and there is no doubt of this. So lowering LDL cholesterol will decrease the cardiovascular risk. And it's well known also to all of you that for every 1 millimole reduction on the LDL cholesterol, the atherosclerotic cardiovascular disease events are reduced after 1 year by 21%. So we moved from the LDL cholesterol hypothesis into the LDL cholesterol causality. Without LDL cholesterol, no atherosclerosis. LDL is really involved in the formation of the plaque and stenosis of our vessels. This is a Canadian-led global studies, the InterHeart, where they identified and a very easy, recordable 9 risk factors. And they found clearly that more than 90% of attributable burden for acute MI is due to 9 modifiable risk factors, of which dyslipidemia, followed by smoking, is the most important one. And here, both of them are modifiable. You can play with them, you can manage them, but you need to put an eye on this. So, we will move now to the clinical values of our very strong drug. Sorry for this interruption. So, coming back to our PCSK9 monoclonal antibodies inhibitions, the evolocumab, Repatha, it's something very strong weapon, when it comes to reducing the LDL cholesterol. We know very well that this drug lowers the LDL dramatically, and it is very strong, and also we know now we need to bring the LDL cholesterol, whatever, using the statin or using whatever the agent, just we need to bring down the LDL cholesterol to see the benefits. What data support my talk when it comes to the evolocumab, to Repatha? We will go back into 2014 when they start recruiting patients to look after the effect of the evolocumab on the efficacy, safety, tolerabilities. And they published the Laplace-2, a phase 3 trials, where they randomized those patients with mixed hypercholesterolemia and primary hypercholesterolemia to the evolocumab, placebo, or to ezetimibe. And they found clearly that our drug is the only PCSK9 inhibitor that showed up to 75%. Look to those turquoise and blue color columns. So it showed clearly that they can reduce and give an additional reduction on the LDL cholesterol of about 75%. So it is an intensive drug, LDL cholesterol reductions. Again, when it comes to the action, it is rapid. There is a rapid onset. See here, when you inject the, evolocumab, within 4 hours, the drug will start working, bringing the LDL cholesterol, the PCSK9 receptors down. So the rapid onset of the action will achieve, in 1 or 2 weeks, a very significant reduction on the LDL cholesterol. And this rapid and maximum inhibitions of the PCSK9 will be seen very quickly within a few hours, and you will see a reduction even within 24 hours on the LDL cholesterol. What is the most important is not only the reduction. You need a sustained reduction over the period of the medications. To your left side of the slides, you can see clearly how is this reduction is sustained and continuous all over the time of the study. Okay, back to the very important Fourier trial, which was announced and published back in 2017 on the American College of Cardiology, Washington, D.C. A very important, robust trial with more than 27,500 patients randomized to evolocumab or placebo on top of the maximum tolerated dose of statin on those patients with established atherosclerotic cardiovascular disease. And they looked after the safety of the drug, and they looked after the percentage change on the LDL cholesterol, and the results came really significant. The drug succeeded to bring down the LDL cholesterol levels from 92 milligram per deciliters down to up to 30 milligram. We are talking here about 60% reduction on the LDL cholesterols. So it showed a very consistent LDL cholesterol reductions with a median follow-up of 2.2 years. And when it comes to the reduction on the cardiovascular events on those patients with established cardiovascular diseases, there was a 20% relative risk reduction. This study showed significant reduction to the cardiovascular events, including cardiovascular death, MI, stroke, unstable angina, revascularization, but it did not show any reduction on the cardiovascular mortality that time, and that's why I'm here today. Okay, so again, when it comes to the safety of this drug, back in 2019, on the Journal of American College of Cardiology, they published this trial, the Osler study. That time, it was a 5-year safety study, and it showed that the drug is really safe, tolerable. The incidences of serious adverse events, a new onset of diabetes, muscle-related events, hemorrhagic strokes, were similar and compared to the placebo, so it was a really safe drug over a 5-year safety trial. All of these data led to a marked change on the international guidelines, and especially the American College of Cardiology guidelines, which takes some time to be updated. So the American College of Cardiology consensus pathway elevated the role of the PCSK9 inhibitors from the current guideline recommendation, and there was a strong reason for them to do so. Number one, these data demonstrated a safety profile, efficacy, and a cardiovascular outcome benefits. And the second point, the improved cost effectiveness of these medication. As you know, it is not a cheap drug when it comes to the price. So here they said clearly it is preferred to use the monoclonal antibodies PCSK9 inhibitions, by their pathway as an initial PCSK9 of choice for those patients with atherosclerotic cardiovascular diseases. And on their algorithm to the management of those patients at very high risk, and we know our all ischemic heart disease, stroke patients, or even peripheral artery disease are very high risk patients. If your patient considered a very high risk and has an LDL cholesterol of 55 milligram per deciliter or more, then you have to consider the PCSK9 inhibitions, monoclonal antibodies like evolocumab and or ezetimibe if still the target is not achieved with the maximum tolerated dose of other medication. Again, if your patient is not a very high risk, but still his LDL cholesterol more than 70, you consider the ezetimibe if still not achieved, but you may consider adding or replacing the ezetimibe with the PCSK9 inhibitions monoclonal antibodies. Let's come to the most important study published back in 2022 and even till date, at least for me, the open label extension of the parent study, the Fourier. They want to look after the safety of this drug in a longer exposure period of the evolocumab drug, and they want to see if this drug will give us, a mortality benefits. Okay, so we will go quickly now into the long-term evolocumab in patients with established atherosclerotic cardiovascular disease, Fourier OLE, which was, announced in 2022 European Society of Cardiology in Spain. Back in the parent study, the Fourier, they recruited, as I told you earlier, 27,500 patients with established atherosclerotic cardiovascular disease. There was a reduction on the MACE. There was no effect on the cardiovascular mortality. Median follow-up that time was 2.2. It was not enough time to look for, other safety and efficacy benefits. Thus, we need a longer studies. So what was the background? Since the first statin got approved back in late 80s by the FDA, the maximum median follow-up for the statin trials were between 4 and 5 years. And they demonstrated clearly something we call it lag and legacy effect. We mean by lag effects, clinical benefits will take time to grow up. You will not see the clinical benefits in 1 or 2 months or 1 or 2 years. It takes some time for lowering the LDL cholesterol to see the benefits. And the legacy effect, when it comes to the clinical benefits, the resistant effect, you should have, a very longer follow-up from your trials to see this legacy effect. Thus, very long-term data were necessary on the safety and efficacy of LDL cholesterol lowering with the PCSK9 inhibitors. This graph shows you clearly from the Fourier how the evidence of lag on the effect on the MACE. You can see after randomizations and up to 12 months, it takes at least 3 to 6 months for the both curves, for the placebo and for the active drug, to show separations, and in this way it shows the benefits. And here we do have a 16% relative risk reduction on the cardiac events, including death, MI, or stroke. Here, when it comes to a longer durations, you will see more relative risk reduction. So you had a 16 in the first 12 weeks, you give it for longer, 12 months, you give it for 3 years, you will see more and more reduction when it comes to the 3P endpoints. So, very simple design. Out of 27,500 patients, they got about 6,635 patients. 50% of those patients were on a placebo, 50% were on the active drug evolocumab, and they continue to follow up those patients. They want a longer exposure of evolocumab. They give all the 6,600 patients an active drug, no more placebo. So the primary endpoint was the incidence of adverse events. This is the most important. Many of you, before they start this drug, they will come and will say, we don't have long-term data about this drug. We don't know what are the side effects at a longer exposure durations. The MACE were pre-specified. Safety evaluation included in all patients in Fourier OLE who received at least 1 dose of the active drugs. And the analysis for major adverse cardiovascular events were conducted on an intention to treat basis and stratified by the original treatment assessment at randomization. When it comes to the baseline characteristics, I told you they choose 6,600 patients from the 27,000, but they choose well-matched people. When it comes to the age, we do have an age of, mean age of 62. When it comes to the male sex, 3/4 of the population of the OLE were males. When it comes to the types of atherosclerotic disease, majority were MI patients, myocardial infarction. We're talking here about 84% of MI. When it comes to the cardiovascular risk, 85% hypertensive, 1/3 of the population diabetic, and 1/4 of them, they do smoking, current cigarette smokers or tobacco smokers. And when it comes to the mean LDL cholesterol level, the mean LDL cholesterol level were 91 milligram per deciliter, which is equal to 2.4 millimole per liters. What is the effect on the LDL cholesterol when it comes to the parent study, the Fourier, and to the open label extensions? You can see at week 12, when those patients of placebo, the blue color, got switched to the active drug, the evolocumab, a significant dramatic drop of their LDL cholesterol, down to even less than 40 milligram per deciliters was noticed. 63% of the population, they achieved even less than 40 milligram per deciliter reduction on the LDL cholesterol. So we do have a significant reductions, and we do have about, all of the patients got reduced into about 30 milligram. Here, the safety is the most important point. The incidences of the serious adverse events in new onset of diabetes, muscle-related events, hemorrhagic stroke, neurocognitive events on the evolocumab long-term studies were similar to those on placebo studies. And it was not increased over the time, and it is very clear here. So the drug is really safe at a longer duration of exposure. Let's come to the efficacy. When it comes to the primary endpoint, the drug succeeded to bring down the risk by 15%. And when it comes to the secondary endpoint, again, it confirmed that the cardiovascular death, MI, or stroke got reduced by 20%, and we have seen this on the parent studies. What is surprising and very important here, the cardiac mortality. In the 4-year OLE, we have seen a 23% risk reduction when it comes to the mortality. This PCSK9 inhibitor, Repatha, the evolocumab, brought down the cardiac mortality by 23%. So, in summary, when it comes to the evolocumab OLE, open label extension trial from the 4-year, the long-term use of evolocumab with the median follow-up of more than 7 years appears both safe and well tolerated. Many of those on the study received the drug even more than 8.4 years. Earlier initiation of the drug evolocumab is associated with continued accrual of cardiovascular benefits, including cardiovascular mortality over the next several years. These findings push us and argue us for early initiation of a marked and sustained LDL cholesterol reduction to maximize the clinical benefits. Very quickly, we'll go to the guidelines updated for the acute coronary syndrome. The European Society of Cardiology, they showed clearly how do you manage the lipid lowering therapies in acute coronary syndrome, the very high risk population. If your patient is naive to a lipid lowering therapies, you are asked as a class 1 indication to initiate the highest tolerable dose of high intensity statin. Okay, and if your patient is on low or moderate intensity, you have to switch him to a high intensity statin. But if your patient is on a highest tolerated statin and his LDL cholesterol continue to be more than the target, which is less than 55 milligram per deciliter or less than 1.4 millimole per liters, then you may ask to add ezetimibe as a class 1 or to add the PCSK9 inhibitors as a class 1. If your patient on highest tolerable dose of the statin and ezetimibe and still you fail to reach the target, which is less than 1.4, you are asked as a class 1 recommendation to use the PCSK9 inhibitors. So, when it comes into the era of early implementation of the drug, you don't wait longer time. You don't wait for months to bring down the LDL cholesterol to the target. The patients come with acute events. You call him back after 4 weeks after you start the high-intensity statins or plus the ezetimibe plus minus. Then you look after the target. Then you decide about your PCSK9 inhibitors. These data are, approved and it's studied in multiple studies when it comes to the PCSK9, including the Evobax, the EPIC, STEMI, including many, many others trials conducted to confirm what we are talking about. And here you are the recent recommendations and the new evidence on the timing of the PCSK9 inhibitions and initiations when it comes to our high-risk ACS patients. On the phase of the ACS, we know very well that the levels of the PCSK9 may be very high, and this will lead to diminish the effect of the LDL receptors, which is responsible for uptaking of the LDL particles. And based on the above, mechanisms of action, early PCSK9 inhibitors treatment has implemented an aggressive therapy for those ACS patients. So it is important to look after the LDL cholesterol for our patients, but unfortunately we are not doing so. From this study, you can see that the LDL cholesterol testing rates for those patients with acute MI, hospitalized, with acute MI, after 1 month only 9%, and after 1 year only 52% of our patients will receive an LDL cholesterol testing. I do have one of my patients, one of my first patients who received the evolocumab. He's a young gentleman, 42 years old, a positive stress testing, and he was, sent to the cath lab. I did a BCI to his right coronary artery back in September 2018. The cholesterol profile, as you can see, the total cholesterol 5.9 millimole per liters, and the LDL cholesterol were 4. We are talking here about an LDL cholesterol of about 150. So this patient was advised a healthy lifestyle. We started him a dual antiplatelet therapy, beta blockers, ACE inhibitors, and atorvastatin 40 plus ezetimibe. Importance of his medication were explained in detail, as usual we do for every patient. Next visit, after 3 months, the patient came. Vitally, he was okay, no chest pain, no events, but he stopped all his medication except for the aspirin and the clopidogrel. And the reason, he got an erectile dysfunction and general weakness. So he took the action by himself. And when we checked his lipid profile in January 2019, the total cholesterol 6.2 and the LDL cholesterol is 4.6. What we did, we explained again about the atherosclerotic cardiovascular risk and how he might develop another lesions. We advised him to continue the dual antiplatelets. We reduced the statin, and we switched to a rosuvastatin 10 plus the ezetimibe, and we started him an injection of evolocumab every 2 weeks, 140 milligram. He was, of course, referred to the urologist, and we stopped the beta blocker, and we don't know what the urologist did for him. So these are his profiles, lipid profile. Remember, when he came in September 2018, his total cholesterol 5.9, LDL cholesterol 4. In 2019, January, it was still high because he stopped his medication. And after 3 months of starting, the LDL, the evolocumab Repatha injections, we succeeded to bring him back, and we did a lipid profile for him. Total cholesterol is only 1.5 millimole per liters, and his bad cholesterol, the LDL cholesterol, is almost undetectable. We're talking about 0.003. Patients remain, events-free until now. He is on the drug, and he's following with us. Thank you very much, and really appreciate it.